This recording will cover Chapter 36 and 37. Antihistamines, decongestants, antitussives, and expectorants are all medications that deal with the common cold. So it's easy. Most of you have taken or heard of them. Most common colds are caused by viral infection. Viruses invade the tissues or the mucosa of the upper respiratory tract, and it causes an upper respiratory infection, or URI. When you get this infection, you have excessive mucus production, and the mucus is a result of the inflammatory response to this virus. So then, fluid or mucus drips down the back of the throat into the esophagus and the lower respiratory tract, and it causes all the cold symptoms that people have, like sore throat, coughing, upset stomach, even sneeze. So it has all this stuff. And so all these drugs treat the cold. And it's combination use. So you could have a variety of one of the four things. Treatment for the common cold is symptomatic, not curative. So you've all heard if somebody has a virus, you let it run its course. It is symptomatic. And it's very difficult to identify whether the cause is viral or bacterial. Some people will say, look at the color of the nasal secretion. So if the color is yellow, it means it's a virus. If the color is green, it means it's a bacteria and you need antibiotics. But some people just let it run its course no matter what it is. Now, you need to understand over-the-counter drugs and pediatric concerns. Remember, in the beginning of this section, I said that over-the-counter drugs are the most dangerous. Tylenol is the most abused drug and the highest drug for overdose. Cold medicine is for pediatrics. So you should not give cold medicine, cough medicine to kids younger than 2. They will oversedate, they can have seizures, tachycardia, and even death. And I hear so many parents say, oh, I'm going to give my kid a little bit of Benadryl so they can sleep and I can get some rest. Benadryl is one of these drugs, the overdose drugs for kids, so be careful with that. And if you hear that, have your little flags up ready to intervene and provide some education. Anaphylaxis is a severe allergic reaction, deals with histamines in the body. You can read that slide, but anaphylaxis is a severe reaction. Before I tell you about these drugs, and before you can understand antihistamines, you must first know what histamines do to the body. Your book calls a histamine a major inflammatory mediator in allergic disorders. A histamine causes allergic rhinitis. Hay fever, mold, dust, allergies cause allergic rhinitis. It's runny nose, inflammation of the nose. Anaphylaxis or angioedema, drugs, insect bites, urticaria, which is itching, these are all inflammatory responses. So antihistamines are drugs that directly compete with the histamine for specific receptor sites. So they counteract these bad reactions. They counteract the inflammatory response. Now, as you can see on this slide, you have 2 different histamine receptors, H1 and H2. So it would only seem natural that there are H1 blockers and H2 blockers. So antihistamines have antihistaminic and anticholinergic blocking abilities. So anticholinergic, you're going to hear that again and again and again. So I'm glad you've already learned what it does, what anticholinergic drugs do. So now you'll notice that H1 blockers, also called H1 antagonists, are the allergy medicine that people take. Then the H2 blockers may not be familiar to many of you since you're all so young, but these are used to reduce gastric acid and peptic ulcer disease. Isn't that weird? We'll talk about that later on in this course. So H2 blockers, peptic ulcer disease. H1 blockers are what we'll talk about today. So H1 blockers block histamine at the H1 receptor site, and the binding of this prevents the histamine from stimulating things that vasodilate in the nose, that nasty allergic rhinitis, runny nose. It also prevents the increased GI and respiratory secretion, so it helps with chest congestion. Antihistamines are more effective in preventing the action of a histamine rather than reversing what happens once the reaction starts. So they should be given early in treatment before all of the histamines bind to the receptors and do their thing and make you really, really sick and inflamed. Does that make sense? So early on, they prevent. Once you have a full-blown allergic reaction, antihistamines don't do much. It's almost too late. So there's lots of different effects throughout the body. The histamine effect in the cardiovascular system allows substances to leak into the tissues. That's what increased permeability means. Reducing dilation, decreasing permeability. In the immune system, now the immune system is the system that causes the release of substances associated with an allergic reaction. Did you know that? That's why it's important that the immune system is addressed when we're talking about allergies. So when you give somebody an antihistamine, the way it affects the immune system is it prevents the histamine from attaching, so it decreases that response, and it just helps stop all the other effects and all the rest of the systems of the body. Antihistamines are used for allergies, hay fever, allergic rhinitis, of course, that's what allergies are, and any random allergic reaction. So, like, my daughter had the flu a couple of weeks ago, and she had they gave her amoxicillin, which they shouldn't have because she's had so many reactions from amoxicillin, but she didn't know, she didn't ask me, she's an adult, and she took amoxicillin, she started getting this horrible rash or hives all over her body. And she calls me freaking out that she's got this rash, and I said, rub a little Benadryl on it. Get some Benadryl cream or take a Benadryl pill. If it goes away, it's just an allergic reaction for the antibiotic, and when you're done with the antibiotic, the rash will go away. So for a rash, Benadryl or some kind of antihistamine product will decrease the histamine response and take care of that, right? So it's just for symptoms, but antihistamines are for all kinds of stuff. Let's see. It's used for Parkinson's. Did you see that on this slide? Why on earth would it be used for Parkinson's? So think about that. The anticholinergic properties of an antihistamine would perhaps help with some of the drooling and secretions occurring in Parkinson's disease, right? Because it dries them up. So you wouldn't want to give an antihistamine if they have a drug allergy. If they have any kind of asthma, any kind of COPD, you wouldn't want to give it. If they have any kind of ulcer disease, if they're pregnant, seizure disorder, if they have BPH, which is benign prostatic hyperplasia, you would not want to give an antihistamine because it's going to dry you up and prevent you from urinating, right? So we don't want that. Adverse effects are the anticholinergic effects. Dry mouth, difficulty urinating, constipation, some changes in vision, and drowsiness. Antihistamines make you drowsy. Traditional antihistamines are older. They have an anticholinergic effect, and they are more effective than some of the non-sedating drugs. But the non-sedating drugs are great. I've taken all three of these examples because I have chronic allergic rhinitis, because I have pets I shouldn't have in my house. And they don't sedate. You take one pill for the whole day. They're great. They work peripherally. They have fewer CNS effects, and they have a long duration of action, so you can take a 24-hour. The older diphenhydramine, you take one every 4 hours, so you're having to pop pills every 4 hours, and it makes you sleepy. The non-sedating new ones, 12 hours, 24 hours, they're great. They're more expensive, but they're great. So, nursing indications you want to use with caution with anybody with increased ocular pressure, anyone with renal disease, because that's how they're excreted, Anyone with hypertension, asthma, COPD, antihistamine will make your heart rate go up, so you want to be careful. BPH, again, we don't want to give it to somebody who's having trouble urinating because it's going to dry them up. We want to teach them how to do mouth care, chew gum, hard candy if they're going to have the dry mouth. And we monitor for therapeutic effects. Antihistamines. So they decrease the inflammation and decrease the allergic response. Okay? Nasal decongestants are next. And this slide shows you the different types. So nasal congestion is excessive nasal secretions because of the inflammatory response and the swollen nasal mucosa. So many times when you have a cold, you might be given an antihistamine and a nasal decongestant. So allergies and cold are the primary reason for taking this. There are 3 types of decongestants. There's the adrenergics, which is the largest group that deals with the sympathetic nervous system. So it's a sympathomimetic adrenergic. Then there's anticholinergic, which is the parasympathetic. And then there's corticosteroids. So adrenergic, anticholinergic, and corticosteroids. Decongestants come in 2 ways. Pill, inhaled, or topical. Actually, I said 2 ways, but 3 ways. Oral, inhaled, or topical. Oral lasts longer, but it has to be absorbed, and therefore it takes a long time to work. And when it takes a long time to work, it's less effective than topical. So the most common oral would be something like Sudafed. That's a decongestant. Sudafed is an adrenergic because it's going to increase your heart rate, right? It does all the sympathetic stuff. Topicals are primarily adrenergic as well. They work very well. Think of Afrin, okay? The problem with the inhaled and the topical adrenergics is they work really fast. But if you have sustained use over several days, you can have some rebound congestion, making the condition worse. Oral ones won't do that. So when people get hooked on Afrin and you hear, oh my gosh, they're hooked on Afrin, it's because of the rebound. They can't stop, they don't want the rebound. So I've got some examples under each category. There they are. Nasal decongestants. What do you use a nasal decongestant for? You use it for anything that causes you to have a runny nose. So you could have acute chronic rhinitis, you could have a common cold, you could have hay fever, any other allergies. You could even, some people put a decongestant in the nose, ear, nose, throat doctors put a decongestant in the nose just so that it clears out so that they can stick their little microscope thing up and look in somebody's nose. So to facilitate visualization before surgery or just to look and see what's going on in somebody's nose. So the way a nasal decongestant works is it constricts the blood vessels that supply the upper respiratory tract. All the blood vessels around the nasal sinuses. So the tissues shrink, and when the tissues shrink, the nasal secretions can drain better. So there are nasal steroids that are used too, and that those are things like Nasonex and Flonase. Those are nasal steroids. They have an anti-inflammatory effect. They turn off the immune system cells and they just decrease inflammation, guys. All of these decrease inflammation. Contraindications, drug allergies, glaucoma, hypertension. So remember, if it's sympathetic, it's going to make the heart rate go up, so we don't want to give it on somebody who's hypertensive already. People you wouldn't give these drugs to, you would not give a decongestant to people who can't tear. Maybe they can't close their eyes because, I was about to say something, okay, I'll just say it. Maybe they had an eyelid lift and they can't close their eyes anymore. That happens to some people. They can't tear, they can't close their eyes to produce tears. You don't want to give them something that'll dry them up. If they have diabetes or hyperthyroidism, you don't want to give them something that'll dry them up. Here's the adverse effects of nasal decongestants. It's the adrenergic stimulation of the heart, blood vessels, and CNS. So if you know a nasal decongestant is an adrenergic and it deals with the sympathetic nervous system, think about what the adverse effects are. So try to use common sense and write terms that you already know. Adrenergic. So sympathetic drugs will cause nervousness, palpitations, tremors, okay? And there's quite a few drug interactions, so we don't want to give this with drugs like MAOI inhibitors. We don't want to give this with we don't want to use more than one type of nasal decongestant together. And we don't want to use it with a drug called methylodopa. Okay, antitussives. These are drugs that stop coughing. So before we talk about cough medicine, which is what this is, we have to understand there's two types of cough. There's productive cough, which is congestive. It's congestive. It's where you're coughing something up. You're removing excessive secretions from your throat or chest. And then there's non-productive cough, which is just a dry cough. So when you are, from this point on, when you're describing a cough that your patient is having, you need to state whether it is productive or not. This is a nursing assessment, so you're assessing the cough. If it is productive, then you have to describe it. What are they producing? What's the color, texture, odor? Now I want you to think about this. Productive coughing does not get a cough suppressant. We want that stuff to come out. What do you think will happen if you suppress a productive cough? It stays in the chest. It stays there. It becomes infected, right? It's gross. Most of the time, coughing is good. It will help remove excessive secretions, or if you're choking, you can cough to remove the foreign body. But there are times, like maybe after GI surgery, somebody has a hysterectomy or a hernia, that coughing would be harmful. So we want to hold their belly, or we give them a cough suppressant so that they don't cough. So we're going to give a cough suppressant to a non-productive cough or a time where somebody may hurt themselves if they cough, okay? Most of the time coughing is good. It removes excessive secretions, or if you're choking, you can cough it up. But there are times, like after surgery, that it's harmful. So we're only going to give cough medicine to someone who has a non-productive cough and who shouldn't be coughing for any reason. Okay? There's opioids and non-opioids. Opioids are going to make you sleepy. Okay? It's great if it's for a surgical reason. Somebody's had abdominal surgery and they shouldn't cough, or they've had their tonsils out and they shouldn't cough. So if you have a painful cough, give them opioids. It'll make them sleepy, and it'll take care of their cough right away. But most of the time, people are going to get non-opioids because they don't sedate or depress the CNS system. And patient teaching is definitely going to be don't drive or operate heavy equipment if you're on an opioid, and notify your provider if the cough goes on for longer than a week. So non-productive coughs, the antitussives, cough medicines. Expectorants. So expectorants help you cough it up. Guaifenesin is an expectorant. They thin the secretions so that you can cough it up. And it's just, they're used for the relief of productive coughs associated with anything that causes a productive cough. So flu, sinusitis, common cold, bronchitis, whatever. People who take expectorants need to increase their fluids big time. Like every time they take a pill, they need to increase their fluids. Okay, I'm running out of time, so this is just chapter 36, and I'll do a separate recording for chapter 37. Thanks.